I would have them ask for an iron infusion. And one of my favorite things to say is if they say no, have them document into the chart that they said no. The cardiothoracic intensive care unit, we were on the ICU. I saw patients who were not conscious. I walked patients with LVADs and RVADs, and sometimes both. We saw all those patients. I was never once on the postpartum maternity floor. Never once. And that blew my mind as a patient. That I'll never forget that. And I'll never allow for pelvic health therapists, PTs, OTs, in hospital, out of hospital. I will never let somebody say, but we're not saving lives here, because that's not true.
Abby, thanks for joining me again. This is our second time on together, isn't it?
It is. I think we should just have like a standing date every few weeks. I think that would probably be best, just to knock those things out, knowing that they're going to come up in discussion.
I agree. I need someone to be angry with. Like, I realize, a lot of what I do is like very uplifting. It's like positive in terms of like, yes, we could do this. There's some things that I really just have to like let go of. And I think you're the perfect person to do that with.
Yeah, rage with me. Let's go.
Yeah. All right. So it's a little bit of a dynamic. I'll be honest with you. I get a lot of things, right, that's said to me, that's messaged to me, that I'm like, I don't know what to do with. But let's just like give you a scenario, and I'm going to try my best to not give all the information out of respect for that person. But I also have to be real with you, Abby. Who am I protecting here? Right. And so listen to this situation. So, very dear friend of mine, a mid-level provider, is now treating in a hospital where, as a matter of protocol, her attending physicians don't order labs if a mom has lost a significant amount of blood but is not symptomatic, meaning hemoglobin has dropped after birth. They're being sent home. No labs really are drawn to kind of determine, hey, let's give an iron infusion. Let's like check this out a little bit. But, little investigation down the road, weeks down the road will show later on, hemoglobin had dropped, like continued to be low after this person delivered. And so as a matter of protocol, they're not giving iron infusions if they lost, 500 to 1,000 or more milliliters of blood if they're up and walking fine. You and I know from a physiological standpoint, after birth, a lot of endorphins. If mom is with her baby, like, yeah, you're not going to probably be symptomatic until boom, a crash happens. Mm-hmm. And so I get information like that. And I get a lot of like, yeah, we didn't do that. And, mom had to come back to the hospital, or there was an infection or sepsis or just something. And it's like, I'm not really protecting your practice by not saying anything. And so I feel like I have to just take it to moms. Like, if you've lost blood, what would you say, Abby? If they've lost blood during birth, what should they be doing to advocate for themselves?
Well, I want to go back to my acute care experience and say that when I was seeing patients, regardless of their surgical history, their current surgical history, or the reasoning for them being in the hospital, when I was doing a chart review prior to seeing those patients, because we go through their chart, right before we see them, we see what their latest blood draws were. And if their hemoglobin was under, what is it? I think it was under 7. They were a fall risk and we didn't ambulate them. So it's very curious that anyone would sign off on them being sent home, because it would be a ding on the hospital to have a readmit. That's where their numbers go down, is if they have a readmit within like 10 days or 10 to 14 days or something like that, it's considered like a ding on the hospital. So that's a really strange protocol to enact, given that they are a fall risk. If their hemoglobin's below 7, if it's below 6, they're transfusing. So that doesn't make any sense to me. Forget about iron infusion. Like, you're getting a full blood transfusion. And different hospitals have different protocols, but if it's I mean, some people were like, oh no, 6.7, we're transfusing, 6.4, we're having a conversation, 6, there's no question. And their crit being, because if their hemoglobin's low, typically their hematocrit's also going to be low. And then we looked at that as PTs as whether or not we would even get them out of bed, because it would be a ding on us because they were a fall risk. So I, for context, have a very similar patient right now. And I guided the patient to advocate for themselves, to have another blood draw. They're postpartum like 4 months, and
Mhm.
they were, I don't believe they lost a lot of blood during their C-section. I think it was well controlled, but they were anemic throughout their pregnancy. And so they went into the C-section anemic, came out of it anemic, and have pica. So they're craving ice chips, chewing ice, which is called pica. And that is when anybody tells me, "Oh my gosh, I'm just totally craving ice chips." I'm like, "Do not pass go. Go right to your doctor and get your blood drawn, because you probably need an iron infusion." And one of the things I said, have a new blood draw and have your old blood draws to show that it's not improving. And hematologists are more likely to, go to a hematologist as opposed to like your GP, your OBGYN, your referring prescription, a preferring provider, if you can, because I think hematologists see the value of giving a bolus in the terms of an infusion and follow up iron pills, because iron pills are not going to get you there really at all. It's too little too late. It's like pain, where they have to break the pattern, give you a bolus, and then give you continuous pain medication, as opposed to, we're just going to keep giving you that dose. It'll never catch up. It's the same thing with iron. So I think the hospital's protocol is strange, because those readmits, those fall risks, the risk of further internal bleeding, because you aren't sure if their hemoglobin is that low, if they have active bleeding somewhere. So like, it's a real confusing, it does not make a lot of sense to me why the hospital would have that protocol. But if they were my patient, I'd probably send them to a different provider to have a new blood draw, and I would have them ask for an iron infusion. And one of my favorite things to say is, if they say no, have them document into the chart that they said no. Please make sure that they documented it, that you requested it, that they denied it, and that not just that they said patient was prescribed iron pills, instructed to take iron pills. Make them put that into the chart that the patient requested an iron infusion and was denied. And a lot of people change their tune when things are being documented in that fashion. But that's a strange protocol.
So here's the thing. Don't you love hospital units that have accountability from other disciplines? Like, let's be honest,
Yeah.
right? Because you can only send someone home after birth if you don't have a physical therapist or an occupational therapist on that unit that's
Mhm.
actually evaluating this person can't get upstairs,
Right.
at least not safely. Like, there are women, and I kid you not, and I've treated them, Abby, and it's like virtual rehab, like, is coming,
Oh,
because
yeah.
I can consult with someone in their hospital room
Mhm.
via via app, and I can tell them, here's what I want you to ask for, here's what I want you to advocate for, and I don't have to be in the hospital room, and we can get those labs ordered. But when you don't have that presence on the maternity unit, here's what happens. They're not getting up and walking and actually practicing the environment they're going to go home to. And I kid you not when I say we have seen women as low as 6.5, as low as 5.7 be sent home, 5.7 looking as pale and as weak, in no shape or form able to carry their baby while they're walking. But yet, if the labs are not drawn, you can say, well, we don't have evidence that we should keep them longer. And so to me, it's no surprise when you left that message, which I'm like, I have to somehow weave this in. When you put that story on Instagram, I was just like, I have got to record this, because this is what's sending women back to the hospital within weeks of giving birth,
Yeah.
right?
Or is the precursor to a more traumatic reason for them to go back to the hospital. They've fallen, they have hurt themselves or others driving, something has happened. And right now we're just talking about the medical ramifications of clearance. Um I was always surprised that I went to every floor. And I mean, I was in the ED. I mean, I was in the psych floor. I was on medicine. I was on the cardiothoracic intensive care unit. We were on the ICU. I saw patients who were not conscious. I walked patients with LVADs and RVADs and sometimes both. We saw all those patients. I was never once on the postpartum maternity floor. Never once. And that blew my mind as a patient because when I had C-sections, the nurse would come and be like, "Oh, no, you have to get out of bed." And I was like, "I can't roll out of bed. What are you talking about?" And I was like, "Can you like assist me in rolling so I can get to sitting?" And they didn't know what to do. And when they gave me their hand to walk me, they were like, it was literally like a limp hand, not even
Oh,
an arm, not even properly assisting under my axilla, no fall belt, nothing to catch me. And I had two C-sections and I knew better because I was a PT and I knew I needed to walk and I knew I needed to get up. And I just did not trust these people. And they're not trained really to do that. They're told to do it, but they're not trained to do it. So it still just does boggles my mind that PTs aren't there to clear people for home when there's an expectation of not only this person who has lost blood take care of themselves, ambulate their home safely, but also take care of this newborn and possibly and probably be nursing and have that energy deficit and that sleep deficit on top of the hemoglobin hematocrit being low, possibly needing transfusion, possibly needing iron. I just can't understand it. And the readmit is just, I mean, I guess in the case of the patient I'm thinking of, it's 4 months, so it wouldn't show up as a readmit, it would show as a new, but that's why I said to bring the documentation from the previous blood draw, which was in the hospital. They discharged her home like that. It doesn't make a lot of sense. The only thing that I can come back to for reasoning is that people keep saying, well, birth is natural. We've been doing this for however long humans have been alive. It's a natural thing. And the more we say that, the less likely we are to treat it as it is, which is a medical event requiring all of the interventions that we offer for every other medical event that enters a hospital.
absolutely. When you say medical event, I have to kind of like bring people out who say that, to the forefront, who say that this is a natural process, who says that, we've been having babies for years, for, the beginning of time, is that had we had the medical interventions that we do now, do we force the uterus to contract
Mhm.
at a rate and at a force and depth that it's not used to where it can cause that muscle to be fatigued and then completely lose the capacity to clamp down on those vessels and stop that person from bleeding. Like if we haven't been doing that since the beginning of time, then we're now entering into not a natural process. It's a medicalized process to have to give birth, right? In the way that it's done. And so if you're introducing interventions, then you must introduce interventions to make sure that that person's birth recovery plan, right, is as optimal as possible. Not just their birth plan, right? We know that a lot of things go left when you introduce a lot more interventions, but now their recovery plan. If you as a physical therapist knew that you needed help just to walk for the first time after a C-section, and you had a professional who was incapable of providing you the support that would make you feel safe, then it is on the liability of the hospital to provide that person or that support, right? That could actually keep you safe and keep you from falling. All right. And so, with that being said, knowing we don't have rehab as an automatic on the birth team, what happens now in this 6-week gap period where we still have pelvic health therapists? To be honest with you, not everyone's doing what you do. And I really want to talk about like what you do, Abby, in terms of like postpartum care. But we know as a standard of care, pelvic health therapists are not typically involved within the first week or two. So those individuals who have had blood loss during birth are weak, are kind of struggling physically after a C-section. What are the options for them?
I don't think anything exists. I think the closest that I hear of existing outside of me telling them, my patients, when you have this baby, you're feeling up to it. I want to know that you're safe and everything's okay. And then I'm excited to hear your birth story. And then let's talk about how we're going to move forward. Outside of that, the closest thing that I've heard of, which I do not think is ubiquitous or everywhere, is a postpartum doula. And that's about it. There are some physicians I know who have routine, some few physicians I know have a routine 2-week virtual follow up. But my concern with my patients lies in my experience with my patients in having a patient who was sent home from the ED. She had severe back pain. She had had a C-section. She had severe back pain. And she and I were on a virtual visit because she was upstate. And I said, I'm not comfortable with the symptoms that you're telling me. You have a low grade fever. You have this back pain. They said they cleared you for kidneys. They did an X-ray at the hospital, and then they sent you home with, pain medication. I said, I'm really not comfortable with it. I want you to not go to the ED. I want you to go back to your OB. And then if they don't speak to you, then I will call them myself. She went back to the OB, and I think probably her partner said that, okay, well, we'll have our PT call you. And then they admitted her, and she was septic. And that, I'll never forget that. And I'll never allow for pelvic health therapists, PTs, OTs, in hospital, out of hospital. I will never, never let somebody say, but we're not saving lives here, because that's not true. Because I do not know if my patient had not gone back to anyone else that she would not have died. If I didn't push her, if I didn't sit virtually with her and her partner and say, I'm not comfortable with these symptoms. I'm not comfortable with what you're telling me that they did for you. I'm also not comfortable with the level of care you received. I really need you to go back to your referring provider until you feel comfortable with what they have said, until they have ruled out everything. And I will tell you that I have a friend from college who was sent home from the emergency room at 39 weeks pregnant with a fever, went to another emergency room, and died of septic shock. These are not abstract stories. And these patients they're real. And it's not because I used to see 60 patients a week. That's not my practice now. So this is not like a numbers game. This is happening in real time to real patients. So it is still incumbent on everyone who is seeing a postpartum patient to ask them the questions about fever, pain, postpartum depression, anxiety, psychosis, to have a screening tool for this. Because if you tell me that, oh, I'm not saving lives, I'm going to tell you all of the stories when I had patients who I looked at them and they didn't look right and they didn't feel right. And I think that we need to take ourselves as professionals a little bit more seriously and stop saying we only do bones and muscles, because we absolutely don't. On the cardiothoracic intensive care unit, walking people with LVADs and RVADs who are waiting for heart transplants, dripping blood along the hallway and ambulating them, that is not just muscles and bones. The level of understanding that you have can absolutely save a patient's life in the same way that understanding the symptoms of a stroke and getting them into the emergency department within an hour can save a person's life. So in postpartum, I think we do need to take ourselves a little bit more seriously. And much like you do, I think we need to push into the first 2 weeks. I think we need to push into the maternity floors, onto the maternity floors. I really tell my patients, like, yeah, the 6 weeks is for an internal exam, but there's a lot of healing that happens prior to that. And there's a lot of discomfort that happens prior to that. And we can work on that together. It's not all about the internal exam. It can't be. That's not, some patients don't want it. So I really encourage my pelvic health brethren to push into those first 2 weeks. Be on the phone with your patient the day they've been discharged. Ask them how they're feeling at home and doing at home. Ask them the kind of support that they have. I just think that if we wait for permission, we will be waiting forever.
Oh, absolutely. That patient that you saw virtually with her partner, how soon after delivery was that?
That was within 2 weeks.
So you mentioned before I asked you, what options do people have who don't have the luxury of having an occupational or physical therapy with them in the hospital? I asked what options were there. Do you believe that a postpartum doula would have been able to kind of follow the clinical reasoning and insist that that person go back to the hospital, for which she was diagnosed with sepsis? Sepsis is one of the main three killers of women in the first 6 weeks after delivery. Do you believe a postpartum doula would have been able to follow the differential diagnosis that you followed to get that person back to the hospital and you saved her life?
No, and here's why I don't think that. Because I have been a patient on a maternity floor post C-section with a bowel obstruction and have had my pain dismissed as gas post-operation. I knew better and had the cell phone numbers of my OBGYN, my MFM who delivered me, my one of my closest friends who actually she delivered me, and the MFM let her assist because she was the chief resident at the time. And I had the cell phone number of my GI, who happens to be the chief of medicine at that same hospital. And the only way that I got the care from the GI team was by calling on a cell phone at home my GI. Not, and I would say that I am very lucky that I have been with a lot of my doctors for a long time, that they know if I'm calling, there's a problem. Most people don't give out their cell phone numbers for very good reasons. But if I hadn't done that and I was experiencing a bowel obstruction and they were telling me it was just gas from surgery and just walk around and you'll feel better, I have no idea what would have happened to my bowels. I have no idea. You know, we could have had a strangulation, and we could have had a bursting of my small intestines. um I don't know what it would have taken for the people on that floor to think outside of the maternity bubble and call in a team. But I have an extensive history, and they still did not take me seriously, saying, I need to be seen by this team. I had to be the one getting on the phone with my doctors. So I don't necessarily think that people who work exclusively in the postpartum maternity hospital space are always the best people at differential diagnosis, because they see so much of the same that they think everything's the same. And for good reason, we think horses, not zebras, but we also need to remember our red flags. And I distinctly remember fever being the biggest red flag, that, like,
Mhm.
for a pregnant or a postpartum person. I remember back pain being a red flag. And I remember that in my reading, that one of the biggest red flags in a pregnant or very soon postpartum patient is the feeling that something is wrong. That internal sense that something is wrong is an actual red flag documented in medical studies, that we take those parents seriously in the feeling that something's not right. And that has been backed up by um a fellow MFM, not a fellow MFM, I'm not an MFM, but an MFM OBGYN on is babies after 35. And I can't recall her name, but she does all this really great content on TikTok and Instagram. And she said that the thing that gives her a pit in her stomach is when her pregnant patient comes to her and says, I just don't feel quite right. And that she said, yeah, I have these other things that are red flags, but when a patient tells me that, I get a pit in my stomach. And basically, it's like, go, shotgun, all of the tests, figure it out, because that instinct tells you something. But I think I'm not confident that, and I love the nursing profession. I love the doula profession. I mean, there are some really, really wonderful people out there, but I just think when you see it repetitively, it sort of calluses you to the zebras. And perhaps I just have not been calloused enough, or that I'm terrified of red flags, but I'm not super confident that the education that is required to be a doula would reach the level of differential diagnosis in a postpartum patient for something like sepsis, or um, or a patient who had postpartum preeclampsia. I think that's really specific medically, and I'm not confident the education supports it.
Or bowel obstruction. The worst case that I saw, and this is when I was treating in the hospital as a physical therapist, on the maternity unit, was a 34-year-old first-time mom. She had a C-section. Within days, she was rushed back to the emergency room, and she had a bowel obstruction, but again, it was passed off as gas. Gas is very common. That gas pain is awful. I've
Awful.
seen women scream, Abby, in pain because of the gas pain, or at least that's what we think it is, right?
Mhm.
With this particular woman's issue was that her intestines had gotten to the point where they were strangulated, because
Mhm.
when you have gas, um, or it's obstructing, the gas can cause almost like what I tell people, it's like an animal balloon,
Mhm.
right? It will literally cause the
Strangulates.
intestines
Mhm.
to
Twist.
twist on themselves like an
Yeah.
animal balloon. And so she had bowel that started to die and burst in one area. And Abby, it ended up in that she had a cesarean, she had a hysterectomy,
Yeah.
right?
Because
So
those
she had
arteries
both
weren't
of her
being fed.
bowel,
Yeah.
hysterectomy. And this woman was a first time mom, probably wanted to expand her family, was not expecting to have a major surgery go back into her C-section, have part of her bowel removed, and then her uterus. When I asked the question about postpartum doulas, I did the doula training. I love that community. I believe they're saving lives and even preventing women from even having to go this route. But then we have a segment of the population who cannot avoid a C-section. And so to put that on a professional that can be a professional with a high school degree,
Right.
who doesn't need any medical background,
Right.
I think that is the ultimate disservice to a major surgical patient population. And to me, virtual healthcare, when done by professionals, can
Mhm.
reach people that we can't physically get to. Virtual rehab is a game changer when you can say to me and to an audience that you saved someone's life and you got them back to the hospital in time for them to still be diagnosed with sepsis, but they're not dead. That to me is like opening an avenue for anyone, femtech, tech industry, whatever, telehealth, to basically say we need to be looking at virtual rehab a lot more seriously.
Yeah. Yeah, I don't think you're wrong. There was one of our pelvic health colleagues, either they conducted a study or they posted about a study that showed no difference in postpartum rehab virtually versus in person. And I think the right clinicians, because listen, in pelvic health, when we are trained in pelvic health, you have to remember, as an audience member who may not know this, we treat children and we treat people throughout the lifespan. We treat men, we treat transgender patients, we treat patients who are very recently who are pregnant, who are very recently deliver. So our scope is broader than just internal exams. That's like, my internal exam is a confirmation bias to what the patient has spent the last 45 minutes telling me, because I have that in my head already. So that's why I tell my patients, if virtual is more convenient for you, we can figure it out. My hands are not the most important part of this evaluation. It's my brain and it's you talking. That's it. I don't need to touch you ever. I don't need to do an internal exam. We do not do internal exams on children. We don't do internal exams on people who are not sexually active. We don't do it on patients who don't want to have internal exams. So that would be a barrier, or say, well, the patient's postpartum 1 week, there's no point in you seeing them, because that's what they're going to say. You can't do an internal exam. So, like, so what do you think that I'm doing? I'm teaching people how to mobilize in bed, get out of bed safely. I'm teaching them how to carry their baby safely, stand up, sit down. I'm teaching them how to bend over and pick somebody up out of a crib safely. I'm teaching them best practices for support under their arms when they're nursing. I'm talking to them about sleep hygiene and the best way to get it. I'm talking to them about their nursing or pumping schedule and how to optimize that for their sleep. We are going over, some patients, it's basic just thoracic mobility. So because they have gone from being pregnant and being in this hyperlordotic position to being in a hyperkyphotic position, and their shoulders and their spine, they're in pain. And I'm talking to patients about how to use their daily movement, as a form of lymphatic drainage if they are swollen, if they have global edema, if they have lower limb edema. Like, tell me those things aren't worth discussing in the first few days of delivery. If you show me a patient who doesn't want that, show me a patient who couldn't benefit from that, and show me who else is doing that. Who? The nurses in the postpartum floors aren't doing it. The lactation consultants on the postpartum floors aren't doing it. Your OBGYN is certainly not doing it. Who's doing it? So I think any parent who has delivered, watched someone deliver, visited someone who has delivered, could get on board with the idea that all of this education could be tremendously beneficial and go a long way to, this is near and dear to my heart, go a long way to preventing mental health illness in the postpartum period. Because sleep deprivation, the feeling that you can't move your body, you're in chronic pain, possibly debilitating pain, that you feel overwhelmed, that you feel like your body's never going to be yours again. Tell me a patient, show me a patient who didn't have some of those feelings and couldn't have benefited from a professional, a medical professional, which we are, seeing them in those early days.
Abby, if I had the thing that does the explosion, I would have done that so many times.
Like a confetti cannon. I want that.
Seriously. If you had, last question, if you had unlimited funding, if you had a line of people waiting and saying, I want virtual rehab, I want some type of option to have care first week that I'm home, right?
Mm-hmm.
Who would be on your team? Who would be on your team to provide those services? I would say you wouldn't be bound by state unless it's, insurance-based, cash-based, whatever it is. Who would be on your team? Virtual healthcare.
The person I would first bring to my team is someone who understands startup business, because I'd want to focus on what they would be like, what would be considered the creative side, because I've been a part of startups and I know enough to know that the business side of it is not my strength, and it would take me too long to learn it to do it. I would want a partner who was ready to handle the business side of it, meaning the fundraising side, meaning talking to hospitals, working through the red tape, meaning how to, the nuts and bolts of the business side. And then after that, I would be looking and talking with the pelvic health professionals, OTs and PTs, who I see as the pushers, the ones who are expanding the boundaries of our profession, because it is going to take an expansive thought process to bring this into patients' hospital rooms, into patients' homes. And those are the people who are going to like the Pelvicon conferences and who are, excited about excited to expand their business practices and meet other professionals and learn about different disciplines within pelvic health. Those people who have that growth mentality within their own business, I want them on my team because I want more ideas on how to do it better. I want their experience, I want their drive, and I want their excitement about our profession.
Okay, Abby, I'm going to do this. And I've been wanting to do this for a long time. So, the space race, the race for first flight, that didn't happen in a bubble. Like people knew that was going on.
Mhm.
So what I am looking to do over the next 5 years is I want to see an app. I don't care who does it. I don't care if I'm racing or, beating someone to it, whatever it is. But in my kind of like in my 12-month goal that I'm doing, I'm part of this Goldman Sachs 1 million Black women business program, right? And
Wait,
that's why
hang
I
on.
was in New York.
Yes, but
And
hang on,
that's
hang
what,
on. Don't
yeah.
forget to flip your hair back when you say that, please. Excuse me. Could you give me a hair flip on that? That's
Yeah.
excuse me. That's worthy of a hair flip. I'm in
Oh,
the
yeah.
Goldman Sachs. Excuse me.
Oh man, this program is amazing, but here's what I want. I want an app where someone isn't consulted like 24 to 48 hours after birth. They're consulted within seconds because we have physiotherapists around the world who are absolutely like on the cutting edge. They are those people. They're those visionaries that you're talking about. I follow one in Nigeria, and she is constantly like she's so tech savvy. She's putting out content every single day about the maternal health crisis in their country, the interventions that a therapist can do in the hospital after C-section. Like to me, this would be an app where any person after birth could connect to a professional while they're still in the hospital or during the first 6 weeks at home. And within seconds, they can talk to a licensed physiotherapist or occupational therapist who does a virtual assessment, who does everything that you were just talking about, who could actually look at their posture, who can ask them about their symptoms, who can look at them, who may even, in the future, be able to connect with their record that the patient is able to upload or connect from their own EMR or for whatever.
Right.
It will have the capacity to connect this person not within days, but within minutes and eventually within seconds to anyone around the world. Amazon already has an app now for virtual healthcare. Did you know about this?
Yeah, I
Like,
read about that.
and people could, poo-poo that, but that's the wave of the future. Like, there's no reason why someone has to wait 6 weeks
No,
to see a rehab therapist anymore after birth.
no.
Like, you don't have to wait that long, especially with the touch of a button. You could connect to someone who can say, you need to go to the hospital. I'm worried about you.
Right. Or
So
here's who you need in the hospital. Make a request.
while they're still in the hospital,
While
right?
they're
Like, don't
sitting there.
leave.
Yeah,
Don't
don't
leave
leave.
until like hematologists.
Refuse to be
Uh,
discharged until
yes.
your recent blood work is uploaded to the system. Like that would be ideal to be able to get on the EMR or to have those shared, because you could say, Show me that this patient's ready to be discharged. Show me them ambulating 15 feet independently without pushing the baby, without holding on to an IV pole. Show me them ambulating 15 feet so they can get to a car. I mean, yeah.
Absolutely. So I'm putting this out there because we're live on YouTube, LinkedIn, Facebook, and Twitter right now. And I choose those platforms. I love Instagram. I just can't figure out how to do it.
You see me
But
on there. I'm just flailing. I don't even know what to do.
change makers, I love it because this to me is a conversation. If you are in the app development world, femtech, I want to see an app that's controlled by patients and not by systems. I don't want doctors to have to sign off for this person to actually be connected to a rehab provider. So this would be a virtual rehab app dedicated primarily to women, to individuals after birth. But honestly, Abby, I see this technology extending to the people that you talked about in your video that even made me say, we need to talk today
Yeah.
because you right now are referring people during menopause, probably after pelvic surgery as well, to virtual healthcare.
Because that's where they're being believed. This is the problem. This is these the wonderful thing about these apps that I talk to my public health friends about is I know I'm going to send my patient there and they're going to be believed. Their symptoms are going to be believed. And I cannot guarantee, obviously, we cannot guarantee that when I'm sending my patients to the ED, forget about it. Hopefully, if I'm sending them back to their OB is like hearing the same things I'm hearing, but that is you want to send them somewhere they're going to be taken seriously. They're not just going to be, tick, 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 that box, you're fine, go.
Why are they being taken seriously via virtual health?
Because it's symptom based, not test based.
What does
Because
that mean?
so perimenopause is a 8 to 10 year time frame. Well, we don't know at any point. So your cycle and my cycle, our body mass index contributed to the leptin hormone that kicked off, the hypothalamus to start the pulsatile uh, estrogen release to pulsatile to get our ovaries to produce estrogen. That starts our menstrual cycle off, kicks our menstrual cycle off in 11, 12, 13 year olds. Yours and mine are different. I could have a body mass index of 21 at the age of 11, 22, and not have a period. And you could have the same and have a period. We also don't know. We have some ranges, but we don't know exactly where your estrogen is in, the luteal phase versus where mine is in the luteal phase. Again, we have ranges, which is what's been studied for reproductive endocrinology. When we're coming into perimenopause, it's instead of it being a regular sine cosine curve, the way that it's been throughout, the longevity of our cycles, it becomes erratic, which is where you get inconsistent symptoms. So you get night sweats sometimes, you get brain fog sometimes. It's hard to pinpoint it. And when we look at labs, we're looking at things like FSH, which is a follicle stimulating hormone. Day 3 is giving you the very best indication that you're possibly in perimenopause. But again, those numbers are very individual to you and your system and your body and how it works. And it is impossible to compare it to another person's. But when you're telling me I have dry eyes, nose, mouth, skin, hair, vagina, my sleep is suddenly disrupted. I'm having the worst time sleeping. My hair is falling out. I have these aches and pains. I'm gaining weight around my midsection. I'm having a hard time in my workouts that, used to be amazing. I have a low sex drive. I'm irritable all the time. And sometimes I get night sweats, but they say my labs are fine. Like you've just ticked off like 12 symptoms of the 67 symptoms of menopause, of perimenopause. Like I'm going to believe you, the patient, that these are the symptoms that you're feeling, that they're different. We're looking for the delta, right? We're looking for the difference, the change over time. I'm going to believe your symptoms and let's start talking about treating your symptoms. And, hopefully people are looking into things like hormone replacement therapy because it's a hormone deficiency that we're dealing with. But you send them back to their endocrinologist, you send them back to their OB, you send them back to their GP, their rheumatologist, and they're saying, well, there's nothing on the lab that I can treat. But this patient's having these classic symptoms that we all know are classic symptoms, you know, not the far-reaching ones like hearing loss and tinnitus, which, by the way, hearing loss and tinnitus, like also symptoms of perimenopause. We're using our scientific minds and we're putting 2 and 2 together and realizing that I don't need a lab to tell me that it equals 4. You're in perimenopause. Let's start treating it. Let's see if we can level out your estrogen to make you feel less erratic in your internal self. Let's see if that helps with the night sweats. Let's make sure that you have a micronized progesterone to protect your uterus, but also to help you have more restful sleep at night. And guess what? They do.
What?
And that's virtual care.
That's virtual care.
I don't prescribe it because I'm not a prescribing physician. However, when people are telling me this and I'm going through my checklist and then I'm talking to them about why this could possibly happen because it's an erratic, irregular drop in estrogen. It's not a linear decline. It's all the way down, right? It's up and down, up and down, up and down on a slow decline over 8 to 10 years. And when I ask them, when did your mother go through menopause? Well, I don't know. When did your older sister go through menopause? Well, I don't know. When did your grandmother go through menopause? Oh, yeah. I remember her saying she went through it really early. So patient history. That doesn't require somebody to be in the office with you. It doesn't require for you to pay real estate in an office to have the expense of a huge staff, multiple waiting rooms, multiple exam rooms. That is not required for these types of visits. And that's how I feel about pelvic health. It's just not required for most good pelvic health professionals, and especially for going through a checklist of red flags, working on ergonomics, bed mobility. That's acute care 101. We all did that in school.
Abby, do you feel like this is a far cry from almost like the traditional pelvic health therapists who are like, no, we need to be doing an internal exam, to assess this person. This is what kind of like defines our practice. Do you feel like this is just getting into more deeper and more holistic, comprehensive work, like virtual healthcare?
I think I'm going to say physical therapists because that's the largest part of my community. I'm going to say that some physical therapists prize their hands more than anything. And I don't know if they were taught that hands-on is hands-on healing. We use our hands. I don't know, because I did hear a lot of that, manual therapy being like, 100 million different certifications for manual therapy, and I'm going to heal you with my hands. Maybe that's left over from just physical therapy in general. I don't know that it's like old school or new school, but I do know some people really prize their hands. I don't, because it's a confirmation bias situation for me. And but I don't feel like it's old school, new school. I think there are some people who are less confident with their differential diagnosis outside of a physical exam. And I think that's probably across the spectrum of medical providers. I don't think that's specific to pelvic health. So I think there are just some people who are less confident in it. But you know what? Frankly, is there a virtual pelvic health course out there where you can teach people putting things together virtually, like how to think virtually, how to think 3D, how to teach a patient to use a pelvic wand at home? Like, maybe
Are there?
I don't
Abby,
think there is.
So you just created one, did you not?
Rebecca, you're a bully.
What in the world? Why would I be called a bully after that?
Bully.
I literally said, I will fund your course. I will fund whatever you need to create it.
Yeah, no, I think that probably would give them some confidence, frankly. I think it would. I think it's foreign to some people. I've been doing it my whole practice, but that's just out of necessity. For patients who wanted to see me, who couldn't see me, who I knew personally, who said, "Can we see each other over video?" And I'm like, "Well, I used to teach group fitness to people without touching them. I can sure do physical therapy without touching people." I do think that it's just a different way of thinking because I think we rely too heavily and are taught to rely too heavily on our hands and not
Abby,
enough on our
I'm
eyes.
I'm gonna do this right now on air. I already told
Bully
you
me.
before platform. Yeah, I am going to. I have someone who just actually wrote in. You can't see the comments, so
Oh
sorry
my
about that.
God.
If you created a course, even if it was a short course, even if it was like a window to something bigger, because honestly, it should be a certification. I'll be honest with you. If you created a course, I will buy it.
Aw.
Okay. In perpetuity. I mean, that means like anyone who's registering over the next 5 years, like you just get a percentage of that registration. I kid you not. Create
Great.
a virtual rehab course for occupational and physical therapists to feel comfortable. I mean, if it's not, you know, if it's not like too much on your plate, go basic, right? These are not therapists who are necessarily like guiding people with wands or anything like that.
Right.
These are therapists who are more likely to see people within the first 6 weeks, right? And so think about what you're doing here. You're creating potentially a whole new field, a whole new subdiscipline. And what excites me is that there are companies on the horizon who are already doing this. Origin, I don't know if you're familiar with them,
Mhm.
Origin Way.
Yep. Origin Way.
They have virtual health offices. And they're doing virtual physical therapy, pelvic health physical therapy in all 50 states. Hinge is
Mhm.
another, right? Sword Health is another.
Sword.
And
Yep.
so if I could see that these companies are really targeting that patient demographic within the first 6 weeks, that would really excite me because now we have data to say, are those individuals more likely to have less complications after birth than people who are waiting 6 weeks to be seen? You and I could probably go on all day. Like, yeah, someone who is seen by an occupational or physical therapist, a rehab therapist within the first 6 weeks, more likely have better outcomes. We can say that. Do we have the data to back it up?
No, because we know that within that up to 63, as much as 63% of patients don't even go to their 6-week visit.
63.
Yeah.
Yeah. And it's probably a lot easier to reach those individuals who have barriers in access to getting back into the office. You can reach them better virtually. So this is more of a marketing issue too.
Yeah.
Yeah.
Yeah. I mean, there are some OBs who my patients are seeing who their 6-week visit was virtual. They didn't do a pelvic exam at 6 weeks.
How
Now,
did they
how now I think that's crazy. Personally, I don't know how they get away with that professionally. Not doing a pelvic exam at 6 weeks, remnants of conception and internal bleeding and stitches and whatnot. Um, but if I mean, it's just such a low bar to
Yeah.
clear, and we just don't prize it just comes back to the birthing parent being just a vessel, and as
Yeah.
soon as the vessel's empty, we have no more use for it, and that's heartbreaking. And the Black maternal health crisis it's beyond a crisis. It's if you're willfully ignoring the death of a certain part of the population that is preventable, crisis is not the word for it. And it doesn't matter socioeconomic background. Talk to Serena Williams, talk to Allison Felix. It doesn't matter. It's not a crisis when we are willfully ignoring the statistic and we know that it's happening. There's another word for it.
On that note, I do have to say this, is that maternal death, it gets a lot of attention, but I think what you're talking about is a lack of compassion. And we're missing out on the fact that not only are we having, Black maternal deaths that far exceed any other race, the morbidity, the long-term disability
Mhm.
of those populations. I'm preparing a talk right now on maternal stroke.
Oh.
And I think about that population, right?
Mhm.
And the amount of rehab that they have to have, like the lack of ability to care for their child, the maternal mental health issues that come along with those impairments. And I think about what you just said, in terms of Black maternal health. And I realize so much attention are on the ones who don't survive. And we are treating the rest of them like empty vessels that we
Yeah.
don't care about. This is a compassion issue. And I think so often of those individuals who actually start to develop complications, not in the hospital, but during those first 6 weeks, there's a huge gap here that we're talking about.
Mhm.
There's a huge opportunity for not your OBGYN. I mean, please do an exam.
Please,
Do an
please,
exam.
please
Like
do
do
them.
a physical exam if you have patients who can come to the office. But for the 63% of people that were missing for their first follow-up or any follow-up after birth, we have an avenue here, technology here that can reach that demographic, right? We just
Yeah.
need to create the systems to train the professionals because they're not getting it in school. DPT's programs are not preparing, not even general entry level therapists to treat one of the largest patient populations in the world, the maternal health population, the most commonly performed surgery in the world, the cesarean section. You have entry level occupational and physical therapists graduating from programs in 2024, not being able to treat just basic patient populations after birth, teaching them how to log roll after a C-section to get out of bed. That's happening. So don't even tell me that you're doing anything on frontline futuristic care of maternal virtual rehab. You're not, right? So we'll need the pathways to create it, which is why I think you're right. I am a bully. I want that course. But secondly, you're saving lives. This conversation saves lives because it's going to put a seed in someone's head. Someone's going to invent an app. We're going to have one in 5 years that allows people after birth at the click of a button to communicate with their not just birth provider, but a rehab specialist. We're going to have that in our lifetime. But we need the bodies to be able to treat that population because it's a lot. 6 million births? Yeah, a year in the United States alone, it's a lot of people. We need the professionals. We need to train them.
I agree.
I'm
You're a bully.
partnering with you, Abby. I don't
You're a
know if it's
bully.
just going to be conversations every few weeks. I don't care how we do it, but I'm partnering with you. I'm holding myself accountable, which is why I have these lives.
Fine, fine. You're a bully, and I love you. And I'm still mad at you for not visiting me when you were in New York, though, because
That's going to change. June, I'm
Goldman
coming
Sachs
back
did
up.
not. I mean, listen, this is like rude.
I love you too,
If
Abby.
you're
This
gonna
was
bully me, do it in
amazing.
person.
Let's do it, June. Let's have a date. I'll definitely stay on with me. We'll talk again. We have to do this again. Thank you all who joined live, gave love to Dr. Abby Bales, one of my favorite, most innovative therapists that I know in the pelvic health, women's health space. Thank you so much for your time.
Thank you for inviting me.